Reuse.
So what will be the subsequent steps after you have applied this stapler for low anterior resection? What will you do?
Then we have to we will do the stapling and the we have to cut the specimens, sir.
So
And then
before you cut, what you have to do? Will you just cut? Suppose you have applied it to the lower end towards the rectal stump.
yes, sir.
Once you apply,
Yes, sir.
the staple is applied. Then you have to
Yes,
fire.
yes, sir.
Once you fire, will you cut straight away or will do something else? Do you need to clamp the proximal side of the gut?
Yes, sir. Yes, sir. Yes, sir.
Otherwise,
Spillage will be there. There
yes.
will be spillage.
Okay. So you have to apply a clamp proximally to prevent spillage, and then you can use a linear cutter or even scissors to cut. And then how do you achieve the anastomosis? You have already seen the device for that. It is done by an end-to-end anastomosis circular.
Circular strip.
Okay. Now, what
Yes,
is
sir.
the use of the second one? Or name one operation where you have used, one thoracic operation where you have used, or where you have seen this.
You can use in VATS, sir.
VATS in which state? I mean, operation. VATS is video assisted thoracoscopic surgery. So
in
doing
esophagus, if
lung
you
resection. No, when you
in
are doing a lung resection, in esophagus also you can use, but specifically for
lungs,
a lobectomy or even
lobectomy.
segmentectomy of lung. So, what is the prerequisite for applying this stapler in when you are doing a lung resection? You have to
Yes.
deflate. So, the patient must be having a double lumen endotracheal tube, and
Okay.
you must deflate the
Single
lung
lung.
that is being the part of which is being resected. Okay.
Okay.
Otherwise, the staples won't be applied properly, and there will be air leak. And then
Yes.
following this, after you have stapled, you may be asked, after the question on staples, you may be asked a question on air leak. What is Sarfolio's classification of air leak? A question like that.
Okay.
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 Okay. Third.
Dr. Shagota?
Yes, sir.
Yes.
Sir, this is an endostapler.
Endo, GIA.
GIA stapler.
Not stapler.
So a clip applicator.
No. What sir meant is, along with stapling, it also cuts. So
Okay.
it is basically an anastomotic device. So it is called GIA, endoscopic GIA stapler. And cutter. Okay.
Okay.
So next is mention any one surgery where you have seen this being used.
Laparoscopic. So can be used for laparoscopic gastrojejunostomy, like
Yes.
Whipple's operation,
Gastrojejunostomy, jejunostomy, following anything, not choledochojejunostomy. You cannot use this stapler, instrument for a choledochojejunostomy. It has to be a GI, gastrointestinal tract, not hepatobiliary system. Okay.
Yes,
So you can use. You may have seen this being used for gastrojejunostomy, jejunostomy, or iliotransverse anastomosis following right hemicolectomy. Okay. What does the arrow point to?
Sir, it shows certain numbers from 1 to 3, 4.
0 to 4.
0 to 4. Sir.
Okay, so what is the significance of those numbers?
So it actually turns and so,
Every time you push the trigger, first
uh,
you finger tight the instrument by adjusting the knob at the end, and then when you put the trigger first, it comes
yes,
to
sir.
0, which means the
Part
cartridges
of
have
the
opposed. Cartridges have
cartridge.
opposed. I mean, sorry, the cartridges opposed with the cartridge house is closed, and then with every firing, what happens? The number changes to 1, 2, 3, 4, which means 1 means 25% of the length that would be cut by this stapler, or that would be cut with this uh, stapler and cutter.
Is
25% of that has been cut. When the number is 2, then 50% has been cut. When the number
50%.
is 3, 75% of the length has been cut. And when it is 4, the
Complete.
entire length has been cut. And when you
Okay.
fire again, it comes back to 0, which means you can now disengage the stapling head.
Okay, sir.
Okay. Okay. What is a newer variety of this kind of stapler? Where you do not have to fire after each step. Just by turning the knobs, you can,
Yeah.
it keeps cutting.
So, have you heard of power stapler?
Yes, sir. Power stapler.
Power stapler. Name some operations where power stapler is absolutely mandatory. Where you have to cut a very long length.
Hemicolectomy, sir.
No. Hemicolectomy, you will have to transect the colon only. In sleeve gastrectomy for
Okay.
bariatric, which is one of the bariatric procedures, there since you have to cut a long length along the entire axis of stomach, so you use a powered stapler
Okay, sir.
to minimize bleeding in course of
Bleeding.
stapling and cutting.
Okay.
Next, who is next?
Who can come? Dr. Mamata?
Any one of you, please volunteer.
Ligation, sir.
Ligation key, is this the generator?
Hand probe, open hand probe.
Handpiece or hand probe?
Hand probe,
Handpiece for open surgery because of the
open
length
surgery.
and from the laparoscopic handpiece and the open handpiece, they look different. So if you have seen both, you can easily mention whether it is an open handpiece or a laparoscopic handpiece. So this is a ligation handpiece. What does the arrow point to? The arrow is pointing to
Uh,
You have to see this device, otherwise you cannot make out.
the arrow is this is the cold knife. This is the knob for the cold knife. After you have coagulated a vessel, you move this so that it cuts. So the ligation device has a mounted cold knife with it. Okay. And what is this purple button? When you press on the finger bows, the switch gets pressed and the bipolar circuit gets complete. Okay. So what is the energy change that occurs in ligation, or what is the energy principle that is employed in ligation?
Bipolar shearer, sir. Bipolar.
So bipolar electric current is applied, and then there is change of electrical to heat energy at the tip.
Yes, sir.
What is the diameter of a vessel that ligation can successfully ligate? What is the maximum size
So
of a vessel?
transversely 5 to 7 millimeters, sir.
When applied transversely at right angles, not
Transversely
obliquely. So 5 to 7
7
millimeters.
millimeters.
In laparoscopic right hemicolectomy, In
sir.
laparoscopic right hemicolectomy, you can take down most of the vessels using ligashore. There is one vessel which must be clipped, and you should not take it down with ligashore. Name that vessel.
Sir, ileocolic vessel, sir.
Ileocolic artery. Ileocolic artery should
Artery.
always be stapled.
Yes,
Okay.
sir.
Next. Who is next?
Uh, uh, Dr. Anand, you have joined?
Yes, sir.
Yeah. We are discussing OSCE instruments. So,
Identify this special kind of bilayered mesh, which is, both the layers are stitched by a layer by elliptical suture line so that it retains its shape. So this is a special type of mesh, self-retaining. Can you identify this mesh?
Sir, I don't have idea about that, sir.
This is a bilayered mesh made of the same material. Both the layers are made of same material. It is not that it is a dual or composite mesh, but both the layers are stitched together so that even if you distort the shape of the mesh, it comes back to its own shape. This is a Kugel patch. This is a Kugel's bilayered patch.
Okay, sir.
It is used in the Kugel's technique of inguinal hernia repair. So in Kugel's technique, where do you place the mesh? Which plane? Anand? Can you hear me?
Sir.
yeah.
If you are not it is not a conventional mesh. You are not placing it where we place. You are not placing it in the normal plane. So what other plane can we put in a mesh in inguinal hernia repair?
Pre-peritoneal or
Pre-peritoneal layer. Pre-peritoneal layer. So the next question that you will be asked is, name some other techniques in which you put in a mesh in the pre-peritoneal plane in case of inguinal hernias.
laparoscopic,
Yes.
sir, tap repair.
Laparoscopic, yes. And in open techniques?
GPRVS, sir.
Do not use abbreviations. What is, always write full names.
Giant prosthetic rheostopa repair.
Reinforcement, that giant prosthetic
Visceral sac.
reinforcement of visceral sac. I knew you
Sir.
did not know the full. So do not use abbreviations, okay?
And NIHAS repair. The DPRVS is both sides, but if you're doing in one side, NIHAS repair is also a preperitoneal mesh placement.
Half stopa, yes. Half stopa or wands repair, or as sir said. So you know all these techniques, and then you can be asked questions about mesh materials. So what are the different materials that are available for meshes nowadays?
Sir, polypropylene polyester.
Okay, next is,
Polytetrafluoroethylene biological meshes, sir.
okay, PTFE meshes. Then you could have a composite mesh like a Vipro mesh where part of it is Vicryl and part of it is Prolene.
Yes, sir.
The Vicryl part gets absorbed and the mesh becomes lightweight later on. And then you could have a
Dual mesh.
Yeah.
or a proceed mesh which you can use for intraperitoneal onlay IPOM. So
Onlay repair.
what are the layers?
Sir, a PTFE one layer is there.
Polypropylene is there, which is the parietal surface. And what is the visceral surface? That is
Polytetrafluoroethylene.
no, oxidized regenerated cellulose, or ORC. Okay, you have to activate the mesh by putting it in water before applying it. Okay, what is the advantage of lightweight mesh? Have you heard of lightweight polypropylene mesh? What happens there? Pore size is bigger. How is the mesh taken up by the body?
So fibrosis.
Through the pores. So bigger the pore, the fibrosis will be more robust, and there will be less foreign body material. The mesh
Yes, sir.
polypropylene is a foreign body to the patient, right? So there will be less of that and more pores. Okay.
Yes, sir.
Anand, have you heard of a mesh called Timex
No,
or
sir.
titanium
Actually,
coated polypropylene mesh?
no, sir.
Where is it used? Titanium coated polypropylene mesh. Can you mention one use other
Any,
than hernia surgery?
Soham and Shakota, have you heard of this mesh? We have used it in some cases. These are alternative to this dual mesh.
Okay.
Yes.
This titanium coated mesh may be used intraperitoneal only mesh placement. It is claimed that the titanium coating of the polypropylene prevents adhesions. The idea of bilayer mesh was preventing adhesions.
This mesh is also used to cover the implant in case of uh, post mastectomy or for implant based breast reconstruction where there is non-availability of acellular dermal matrix and you're putting in a prepectoral implant. You can use this titanized mesh. Name one non-hernia surgery apart from what we have already discussed where you use a mesh.
Non-hernia surgery.
Non-hernia surgery where you may have to use a mesh.
The rectopexy.
Yes, rectopexy. And then questions maybe from rectopexy. What are the various procedures for rectopexy? You can do laparoscopic open, abdominal approach, perineal approach, okay, suture rectopexy or mesh rectopexy, again anterior or posterior,
Posterior.
depending on where you are fixing it. And then, all of this, whether you are resecting a part of the sigmoid colon or not. So it's either Ripstein procedure or Goldberg procedure of the perineal procedures, Altemeas, Delorme's. You must know the name and principles of those surgeries.
Okay,
Okay.
sir.
Okay. Identify these. Who's doing this?
Who else are there? Anand.
Or Arumda.
Yeah. Anyone, please don't waste time.
Whoever wants to volunteer can.
The optical utrocar, sir. Is it optical utrocar?
No. OptiView, those have the entire
Transparent
lens
material.
as
Huh?
transparent. This is
This,
metal,
this is
but
not
there
a
is a
problem.
balloon.
Balloon choker and cannula, sir.
This is the balloon trocar and cannula. Next is what? In which operation have you seen this being used?
Sir, totally extraperitoneal mesh repair in cases of inguinal hernia.
To create
Uh, Space in the
initially while creating the space.
space. Yes, sir.
There you have seen this being used. Any other use? If you are doing a retroperitoneoscopic procedure again to create space, you may use. What kind of telescope will you use for space creation?
0 degree, sir.
0 degree. That is important. 0 degree scope is used with this kind of trocar and cannula. And from there, you may be asked, how do you sterilize the trocar and cannula? Because in laparoscopic procedures, port site infection is dreaded. Previously, we used to clean the instruments, put them in glutaraldehyde and then in formaldehyde chamber, and we used to wash it again before procedure and use it. But to ensure that there is no port site infection, This is a metal. I'm not talking about balloon trocar specifically. Any metallic trocar and cannula. How can you sterilize?
What are the newer gadget available in the theater? Most of these can be autoclaved. That is one.
Ethylene oxide.
So
Yes.
you can first of
ETO.
all autoclave, as sir said,
ETO.
because this is a metallic instrument without any perishable part. So you can do autoclaving. Next is
The plasma
Ethylene oxide.
sterilizer can be used.
Yes.
plasma sterilizer or ethylene oxide. So
Yes,
what is
sir.
the problem with ethylene oxide sterilization?
You have number of surgery, 4, 5, 6 surgery. Can you manage with the ETO?
No, sir.
No, sir, it is time consuming.
Yes,
How
it's
much
time
time?
consuming.
How much time?
Sir,
12 hours. Whereas
12
plasma
hours,
does
yes.
it much faster. So, and the problem with ethylene oxide sterilization is that there are toxic effluents, toxic gases. So there has to be a proper way of uh, disposing that gas through proper, chimney, and because if that is inhaled, it is toxic. So to set up an ETO, to have an ETO setup, it's difficult. So plasma. And what about chemical sterilization? You can use 2% glutaraldehyde. So what time is required for sterilization and what time is required for disinfection? Questions like this will be asked in OSCE, very specific. Glutaraldehyde, if you keep it for 20 to 30 minutes, there will be disinfection. But for sterilization, you have to keep it in glutaraldehyde for 4 hours. What is OPA? Orthoparaldehyde. You can also use peracetic acid to maintain the, these solutions can be added as buffer. Okay. Now regarding autoclave, since we have discussed autoclaving once, let us have some important points about autoclaving discussed right away. So what is the principle of autoclaving? এগুলো বলো. These are very common questions. What is the
The
principle of
moist
autoclaving?
heat under pressure.
Moist heat under
So
pressure. How much heat and at what temperature and what pressure and for what time?
So 121 degrees Celsius and pressure is 15 pound per square inch for 30 minutes.
30 minutes for metallic instruments and for rubber items,
Telecommunications.
15 minutes.
Half time.
10 to
But
15 minutes.
what is the current settings that is being used in the CSSD high, where there is a high burden of autoclavable items? In CSSD department, what is the temperature pressure setting that is being used nowadays?
Most of the hospital has a central CSSD department. They do the whole hospital sterilization, where huge bulk is being sterilized. So what machines are there? Same as you have smaller units in the operation theater?
No, sir.
134 degrees,
134 degrees centigrade,
30
30
pound per
kg,
square inch pressure. And how long does it take?
3 to 5 minutes.
Yes.
Yes. So you can sterilize fast. Okay. Okay, next one. Identify this and why is it not a three-way Foley's catheter? Identify this tube.
The Sengstaken Blackmore tube to control variceal bleeding.
You say Sengstaken Blackmore tube
Blackmore
first.
tube. Yes, sir.
Then the next question is why is it not a three-way Foley's catheter?
So it has two balloon parts, one for
It has
the
two balloons,
esophagus,
and the
one
balloons
for
are
the
much proximally located on the tube, not at the tip.
proximal. Yes,
Okay,
sir.
what are the balloons meant for?
Sir, the one proximally for the esophagus and distally for the stomach,
Okay.
to occlude the variceal
Now,
bleed.
what is the clinical use of this?
Uh,
It is used in a patient presenting with variceal upper GI bleed with hematemesis. So
Upper
you apply
Yes.
tamponade with this, and then what do you do? What is the definitive management following this?
So medical management and endoscopic control, endoscopy, upper GI endoscopic control of the variceal bleed by.
So what are the procedures that are available for controlling variceal bleed through endoscopy?
So laser ablation,
What
sclerotherapy,
is simple thing? Yes, first is sclerotherapy.
sclerotherapy.
Sclerotherapy with you can enhance your answer. Just sclerotherapy is not complete. Sclerotherapy with
Uh,
What is injected on the varices?
you can use sodium
vasopressin.
tetradecyl sulfate or you can use polidocanol.
Okay, so
If you do not have anything, just tamponade. How can you achieve?
so by deflating the balloon,
You can
endoscopically, sir.
you can inject 13 ml of saline and adrenaline. You
Okay,
can give
sir.
adrenaline injection. You can
Electrophoresis
okay. So that
Okay, sir.
also gives tamponade. Okay. Now
Yes,
for
sir.
non-variceal upper GI bleed, how many times you can attempt endoscopic control of bleeding?
2 times.
2 times. Even if there is continued bleeding after 2 attempts of endoscopically controlling it, then you take the patient up for
Surgery.
surgical control of bleeding. Now,
Yes, sir.
type 4 gastric ulcer is there, bleeding gastric ulcer. What are the surgical procedures that are classically described for type 4 gastric ulcer? এরকম specific questions দিতে পারে. If you have gone through the algorithm of management of upper GI bleeding in Schwartz or Sebastian, you will see for type 4 bleeding gastric ulcer, they have mentioned some procedures. SND's procedure. হ্যাঁ আরেকটা আছে তোমার ম্যাডলাং কেলনার প্রসিজিয়ার পশেটস
method.
প্রসিজিয়ার so এরকম ভাবে লেখা আছে so you have to write those names very specific answers the answers will be short and crisp okay okay now name one operation where you can use either of these instruments তাহলে এইরকম একটা কোয়েশ্চেনের মধ্যে 3টে পার্ট কিন্তু you have to identify both these instruments and then name the operation in which both can be interchangeably used.
Common bile duct exploration
Common bile duct exploration and extraction of
and,
CBD stone.
and
Just
extraction of
exploration
the
তো আর
GB
এটা
stone.
use হবে
Yes.
না হ্যাঁ তাহলে
হ্যাঁ, sir.
what are these two instruments?
Sir, the instrument marked 4 is a Fogarty's catheter used for mainly for laparoscopic uh,
Not only
while
laparoscopy, you can
doing
use it in open also because some
laparoscopic
people believe that
common bile duct exploration and extracting the stone.
not only laparoscopy, you can use it in open also because some surgeons are of the opinion that if you
Okay,
use a metallic instrument, you may damage the common bile duct. But we use this. Now you describe the choledocolithotomy, Desjardins choledocolithotomy for us. Why do you say it is Desjardins? One or two, basic questions like this will also be there. First of all, there is no
Catch is there or
no
not?
catch,
Ratchet,
sir.
ratchet.
At the
But
end
no
of the
ratchet.
no ratchet, no
ratchet,
ratchet, sir.
finger bows are there, the shaft is long and
Yes, sir.
curved. And what do you have at the blade?
Relatively or traumatic.
Hmm?
Relatively or traumatic, sir.
It is elongated with
Fenestration.
Yes.
fenestration at the edge, and
There are region groove for better holding.
Hmm.
See
okay.
the blade. There are region groove in the blade.
Yes.
So apart from these two instruments, what else can you employ for removing CBD stones?
Sir, we
Folio.
can use a Foley's catheter, sir, also, if
And
the
Catheter is
Fogarty's is not available.
and endoscopy also use another instrument.
Dormier
Folio.
basket.
Yes.
Dormier basket. Yes, Dormier basket.
Yes.
Now again, there are two instruments. One is a retractor and the other is a curved forceps. Identify these two instruments and mention some operations where this is used, but was used. Nowadays, these procedures are mostly done laparoscopically or percutaneously. But previously, when we used to do these by open techniques, we used to use these instruments. So there is one retractor, which is also called eyelid retractor or Gilbernet retractor, and there is one very curved stone extraction forceps, which is also called a pyelolithotomy forceps. So these two instruments are used in which operation? Open pyelolithotomy, open pyelolithotomy or extended pyelolithotomy. Now you tell me what is the use of the Gilbernet forceps specifically. Gilbernet forceps. I mean, not forceps, Gilbernet retractor. It is a delicate retractor which is placed at the junction of the renal parenchyma and the pelvis to expose the pelvis before you incise on the pelvis to extract stones. Now, from this, you will be asked what are the modern alternatives for kidney stones? What are the modern alternatives of treating kidney stones? Follow? Mention some modern options, alternatives.
Yeah.
Sir,
Anand.
endoscopic
PCNL can be
shockwave
done.
lithotripsy.
PCNL first of all.
हाँ,
Percutaneous full form গুলো বলো তোমাদের কতবার বলতে
Percutaneous
Percutaneous
nephrolithotomy.
nephrolithotomy.
percutaneous nephrolithotomy.
Hmm.
Anything else?
RIRS
Sir,
মানে retrograde internal
lithotripsy.
surgery.
RIRS full form is
Retrograde internal
Retrograde
surgery.
intrarenal surgery.
No,
okay. Somebody said some endoscopic or something. What was he saying?
Sir,
lithotripsy.
endoscopic shockwave lithotripsy.
It is not endoscopic.
Oh, sorry.
Extracorporeal.
Corporeal.
Extracorporeal software.
Extracorporeal.
Common
Yes, sorry,
mistake you commit in the exam.
Again,
That's why
again,
I
please.
specifically.
For each
Why?
one person answer. Okay, please.
So it is not endoscopic. I heard that somebody said that, so I specifically pulled this up. It is extracorporeal shockwave lithotripsy. Now, what is the prerequisite for extracorporeal shockwave lithotripsy?
DJ stent can be placed. Prerequisite.
There should not be any distal obstruction. What will happen if there is distal obstruction?
Stain stress.
Stent stress. So there will be staircase-like phenomenon and the stone fragments will be stuck. So you have to ensure there is no distal obstruction. And number two, the stone must not be very hard. So you must assess the Hounswell units of the stone before you choose whether you want to do ESWL or not. Okay. Have you understood?
Yes.
Okay. Now, what are the different types of pyeloplasty?
Sir, Anderson-Hines pyeloplasty.
So, there are two types of pelvis, extrarenal pelvis and intrarenal pelvis. If there is extrarenal pelvis, you can do dismembered pyeloplasty, which is Anderson-Hines can be done on those cases. And if there is intrarenal pelvis, you have to do a YV Foley. YV plasty, Foley's YV plasty. Okay. Now, apart from these surgical techniques, how else can you manage PUJ obstruction? You
PUJ
can do
obstruction.
endoscopic pyrolysis, or you can use laser. Those things are also there nowadays. Okay. Can you define hydronephrosis, one of you? Define hydronephrosis.
Sir, it is the dilation of the pelvic calyceal system.
Aseptic dilatation, first of all. It is an
Aseptic.
aseptic dilatation. Pyonephrosis or hydronephrosis, how will you differentiate? So it has to be aseptic dilatation of the pelvic calyceal system due to what kind of obstruction of the outflow tract? What kind of obstruction?
Intermittent obstruction.
It may be a partial
Partial.
obstruction or an intermittent complete obstruction. So see, basics have to be very clear. After you are given these two instruments, you will be asked, mention one operation in which both of these instruments may be used, and then define hydronephrosis. If you cannot define hydronephrosis correctly, you will not get any mark, because the keywords are all given in the answer key, and if the keywords are not matching, you keep losing points. Okay. Now from these three images, one radiology, one patient picture, and the instrument itself, you identify this instrument.
Sir, is it a chemo port?
This is a chemoport device. What are the parts that are visible here? There is the chemoport chamber and a catheter along with the lock that connects the two. Okay. So which veins are used for putting in a chemoport commonly?
Internal jugular vein.
Right IJV is the commonest site. Right IJV, because
Right,
it has
right.
a straight course. Or even in the subclavian vein. Where do you put the chemoport chamber?
Yeah, that.
Hmm?
Sorry, sir. I don't have idea that.
It in the infraclavicular area, just in the prepectoral plane, or you do not keep it just subcutaneous because of fear of expulsion. So you make a deep pocket and put it there. Okay. What kind of needle is used for injecting drugs through the chemoport or for aspirating blood through the chemoport? There's a specialized needle so that the silicone covering of the chamber is not damaged by the needle. Do you know the name of the needle? It's a Huber needle. Heuber. These things are asked in DNB exit exam, where you are expected to know a little more than the MBBS students. Now, chemoport is placed in all cancer patients. I mean, wherever you need to, have a venous access for a longer duration. But there are some patients in which you must put a chemoport. So give one indication where you must put a chemoport. With respect to CA breast, you say, when mention one or two situations where you must put in a chemoport.
The hard to new positive cases, trastuzumab for
First of all, somebody who's already received NSCT and now you're operating on the patient, you are doing mastectomy or something, and you realize that there is no proper venous access that is being possible for the patient, and the patient is HER2 positive, will require Herceptin for a long duration, you can put. But what is the absolute indication? Bilateral CA breast, where you are going to do bilateral axillary lymph node dissection. Such a patient, you must put chemoport, because both the arms cannot be used for giving any further chemotherapy. Okay.
Okay, sir.
Now, same instrument, older variety and newer variety. Identify this instrument.
Vedes needle, sir.
Veris needle.
Veris needle. So how do you make sure that Veris needle is inside the peritoneum? This is one patent question. Few points are there.
First we do aspiration, sir.
No.
There will be no
aspiration is later. First, while you are putting in, how do you make sure that you are inside when you are putting in?
The loss of resistance.
2 clicks and then
Clicks.
loss of
2 clicks.
resistance.
Resistance.
And then you
Yes.
try to move the needle, it moves freely.
Freely.
And then you do
Aspiration.
and
Then give
Water
injection
drop.
of saline.
water drop
Then,
test. Yes.
and
What is the flow rate? Maximum flow rate through a Veress needle?
1 to 2.
2 lit. Maximum যখন বলেছে, it's not a range.
2.
Maximum is
2.
maximum. Okay. 2 key.
2
What is
liters per minute.
unless you write unit, it's not complete. Apart from insufflation, have you used Veress needle being used in any other step of any other operation? Suppose you are doing tape and there is a peritoneal rent. What do you do?
Sir, for deflation we can use it also.
So you keep putting a Veress needle inside the peritoneum and you leave it as such for whatever gas that is going into the peritoneum to escape through the Veress needle, so that the space you have created in the pre-peritoneal space is not compromised. And you can also use it as an alternative to an aspirator, GB aspirator. Suppose you have a very big mucosil or empyema, you can use this. Okay.
Okay, sir.
Now this one, 2 varieties of the same instrument.
Harmonic scalpel, sir.
This is a harmonic shear or harmonic
Yes.
scalpel handpiece with transducer in the first picture. Handpiece with transducer. You must know which part is called what. And in the second instrument, you see the handpiece along with
Laparoscopic.
torque. That is laparoscopic. It is longer and you can see the torque. So what are the different lengths of these instruments? Open এর জন্য do you know? For open procedures, they are smaller, 9 centimeter handpieces, whereas 17 centimeter and northwards are for laparoscopic. Now, what is the use of this torque? This portion which I am showing with my cursor.
Torque it will tighten the assembly.
Yes, after you have tightened the assembly, you apply 2.5 rotations on this torque. Torque means rotational force, so that it is absolutely hand tight. And absolutely tight. The assembly is absolutely tight. And then next, what do? You
Activate.
You activate. So what does minimum and maximum signify in either the foot pedal, if you're using the foot pedal, or on the hand switches, these two?
It is shown as a 3 and 5 usually.
Yes, sir. Minimum will coagulate, sir, and maximum will cut also.
Maximum will cut. What is the energy change that occurs in a harmonic device?
Sound energy to heat energy.
Ultrasonic to heat energy.
Yes, ultrasonic to
heat energy.
What is the frequency?
Mega.
That is ultrasonic energy. So what is the frequency at which it works?
20,000 to 50,000 hertz.
20,000 now. This one is a harmonic, so patented device. It has a specific range, 55,000 to 60,000 hertz, or 55 to 60 kilohertz. Okay.
Yes.
Identify these.
One
So
one
this is
one
a
person take this.
vascular clip, sir.
Applicator first.
Clip applicator and vascular clip.
Or hemolock clip.
Hemolock clip.
What is the advantage of this kind of clip?
Sir, this has got a lock system at its end.
So that it is self-retaining. Even if there's a very versatile vessel, it will not get dislodged. So name some operations where you have seen this being used. where it must be used?
Sir, in hemicolectomy,
In hemicolectomy for controlling which vessel?
The
in left,
ileophilic.
sir, inferior mesenteric vessel.
Yes. Ileocolic you said yourself only, na? In right hemicolectomy. In solid organs, splenectomy, nephrectomy, adrenalectomy. So what are the vessels that you clip in adrenalectomy?
Do you
Huh?
need to clip all the adrenal arteries all around, or need to clip only one vessel?
You clip the what is the blood supply of the adrenal gland? One of you. There are multiple arteries.
Arteries.
তার মধ্যে named arteries গুলো, what are the named arteries? Superior suprarenal, middle suprarenal and inferior suprarenal. তাই তো? Sorry. And they are branches of superior suprarenal is a branch of inferior phrenic. Middle suprarenal is a branch of aorta. I mean abdominal aorta, and inferior suprarenal is a branch of renal artery. And you have how many veins? Generally you have the renal vein, the one single adrenal vein or suprarenal vein. Where does it drain?
Right side, left side, same or different?
This is basic.
The left side drains in left renal vein, and right side
Yes.
directly into
IVC, or at the junction of IVC and renal vein, or sometimes higher up even to the hepatic vein. Okay, so clip is used to control the vein. Arteries can be taken down with energy device, bipolar or ligasior or harmonic. Okay.
Yes, sir.
You people are being stumped
Yes.
by basic questions. Okay. Identify these instruments. Two varieties of the same instrument.
So open clip
Clip
applicator.
Open clip applicator, first sector, and second one is also an open clip applicator, but there is it is preloaded with multiple clips. So it is a preloaded multi-load clip applicator. Now name some operations where you have seen this being used. Bolo, any open operation where you avoid tying a lot of vessels, but there are a lot of vessels that need to be tied, like,
Whipple's
and
procedure.
when you are very close to major vessels and you cannot tie all the branches are very short.
Modified radical neck dissection for vascular.
Modified radical neck
Vessel.
dissection you can use, but somebody said Whipple's. Whipple's, definitely Whipple's, while you are dissecting the uncinate process, when you are clearing off the, when you are doing the posterior dissection, you cannot tie all vessels so deep, so you can use this. Or even for
liver resection.
liver dissections, you can put clips on the small vessels where do not have a very big stump to apply suture, then cut, or where the vessels are very delicate. Apart from this, mention one operation where you have seen this being used, where you are using it not for hemostasis. Not for hemostasis.
Uncinate process resection.
No. Actually, even in open cholecystectomy, you can put open clips on the cystic duct before cutting it instead of tying the cystic duct. But apart from any such occlusion, either hemostasis or occluding some luminal structure, apart from that, these clips are also used in, after you have done breast conservation surgery in breast cancer, you apply clips at the
Walls.
Margins of the cavity.
tumor bed.
Okay. Now, what are these clips made of?
Titan.
Titan.
Yes.
Titan.
Good.
These titanium clips are MRI compatible or not?
Compatible.
Compatible, sir.
MRI compatible, sir.
Okay, identify these two instruments and mention the types.
The
Sir,
suction and
above, like,
Laparoscopic suction cannula.
Laparoscopic word is important. Somebody said just suction. No, this is a laparoscopic cannula for suction
suction,
and only suction.
irrigation.
Irrigation.
Suction
irrigation.
and
And
irrigation.
irrigation.
And what are the two mechanisms that are being shown here that are
Above
employed?
one is trumpet.
Trumpet type and toggle type.
Type.
Okay. So what is the diameter of suction cannula? You can have both 5 millimeter and 10
10
millimeter.
mm and 5 mm.
Mention one operation where specifically 10 mm is required.
Laparoscopic drainage of liver abscess.
Liver abscess তো it will be pass only. সে তো যে কোনো cannula দিয়ে বেরিয়ে আসবে.
Hydrated,
Wider cannula will be required.
in hydrated, you need a wider cannula so that even the membrane can be sucked off.
Okay, sir.
So what are the procedures for, what are the interventions that you can offer a patient of hydatid cyst? Finally, all questions will end up in some important topic.
Okay, sir.
Instruments are basically gateway to another topic for discussion. So what are the various options for managing a hydatid cyst after you have done with conservative and medical management? So you can do PAIR, you can do PVAC, or you can do laparoscopic deroofing and evacuation of contents, or you can do an open surgery. Open surgery, generally what do we do? What do we do? What are
Is an
the
operation called as
Pericystectomy.
partial pericystectomy. Cystopericystectomy. You have to take the whole cyst and part of the pericyst.
So the surgery can be classified as conservative and radical. So of which commonly what we do is a cystopericystectomy. Sometimes you can do just deroofing and evacuation of contents and management of the cavity. What are the various methods of managing the cavity?
Capitonage can be done.
Capitonage, omentoplasty, introflexion, যা যা আছে সব লিখে দিতে হবে. What will you do if you see there is bile leak from the margin of the cavity?
We'll put drain and later do MRCP to
It classifies minor bile leak. You can overrun with suture.
3 millimeter কম হলে you can overrun with suture, but if it is a major bile leak more than 3 millimeter, তাহলে you have to do a
give a drain.
metric bypass.
Yeah.
Okay. There are 10 more instruments, but I think we have run out.
We'll take another session. Okay. We'll take another session.
তাহলে next month এ যেটা স্যার স্পেসিমেন আছে ওটাতেই আরো বাকি 10টা যে আছে ওগুলো ডিসকাস করে নেব, আরো কয়েকটা অ্যাড করে দেবো ইনস্ট্রুমেন্ট।
ঠিক আছে।
Thank you very much, sir.
Okay. Thank you.
Sir.
Thank you very much, Dr. DHRITIMAN. You see, these are all atypical instruments here shown. They are not commonly discussed. Okay, you should know all these aspects. Also, you should be knowing the suture material also.
সুচার ম্যাটেরিয়াল আছে স্যার পরের গুলোতে, ওটা নেক্সট ক্লাসে ডিসকাস করব।
Okay.
Okay.
Thank you very much.
Thank you.